Hi, good afternoon, everybody. My topic today is going to talk about the failed primary ACL reconstruction, the tips and tricks in management. In the next 20 minutes, I will take you through about why ACL reconstructions fail and how to identify the failures, what are the commonest causes of these failures, and how best to address them in the best of your ability. So as we know, the growing numbers of ACL injuries and and what's happening is there's more ACL injuries happening, more surgeries are being done, and naturally we are seeing more and more revision ACLs and ACL failures. And this is basically a lifestyle activity which we tend to be more active these days and do a lot of contact sports, physical activities, resulting in rising ACL revision surgeries. So who are the candidates which are candidates for revision ACL reconstruction? It should be young active patients who demonstrate symptomatic instability. Doesn't mean that a person comes with pain after ACL reconstruction, you need to revise. Every post ACL reconstruction patient doesn't need revision. You need to identify which are the patient which is suitable for revision, because we know the results of revision is generally lower than a primary ACL reconstruction. And managing expectation is a very important part in seeing and managing this patient. First of all, I would like to address what are the causes of recurrent instability. I will start with the most common cause, which is the traumatic failure. The most common cause basically is inappropriate. The patient start moving too fast. The graft has not incorporated to the bone. Accelerated rehab is done, and the graft has not healed and basically ruptures. I also see commonly there's a trauma before the graft incorporates, which is spoke about premature return to sports, and sometimes heavy repetitive sports and contact sports too early also causes failure. And the atraumatic failure, which is another commonest failure, is the most common is a technical failure, which is tunnel placement. I think I can say in 20 to 70% patients I see, the most common cause of failure is wrongly placed tunnels, tibial tunnels and femoral tunnels. Tibia being too anterior, causing excessive tension in flexion, especially failure to flex fully, and sometimes causing failure of the graft. And femoral tunnel being too anterior, causing notch impingement and graft failure. And the other one is graft selection. I think in revision ACL reconstruction, I'll try to use autografts as much as possible. But if I need to use allograft, I want the patient, the failure of allografts are higher. And again, graft selection. Autografts as well, got hamstrings, got PTB, got quad tendon. All of them comes with different properties, different qualities. And you need to understand your enemy. In patients who have a medial side ligament injuries, MCL injuries, recurvatum knee, unforgiving knee, which is loose jointed, you don't want to use a hamstring graft. You may want to use a bone patella tendon graft, which is more solid, which is a probably better graft in revision ACL surgeries, especially when you're revising a hamstring graft. Graft tensioning is another tool as well. If the graft is too lax, not tension enough, you get laxity. If too tension, you cannot either extend or flex your knee. So appropriate tensioning is important. Fixation. I'm always a strong believer that in tibial side, you need double fixation. You need a screw and a staple or whatever. You understand your enemy. And sometimes in a revision surgery, your fixation is important. And revision surgery, most of the time, you end up doing not aperture fixation, but you may end up doing a suspensory fixation. So double fixations are also important. The other causes of recurrent instability which cannot be overlooked is associated injury, which is medial side injury, namely the MCL injury, the posterolateral corner injury, the anterolateral structures, which is now commonly talked about ALL or the Sigon's ligament. This is an important component of ACL, and especially when you're talking about revision ACL surgery. Look at it. If you don't look at it, you're not going to find it. You have to look for it. Look for the Sigon's fracture. Look at the chip fracture on the lateral side. If you suspect a Sigon, and especially in revision ACL, it has been my practice do a ALL reconstruction in most my revision ACL, which I'm doing, revising them. I find that central pivot and the outside control of rotation is important, because central pivot alone may not be enough. Look at the meniscus. If the meniscus is torn, especially if there's ramp lesions or there is a basically lost meniscus, your revision ACL is going to fail because meniscus act a very good anterior posterior stabilizer, a secondary stabilizer apart from your cruciate ligament. The other features are the biological. Whether the biology has been there, is there been infection, is there arthrofibrosis, is there anatomic factors? These anatomic factors, the last factor here is important. Look at the tibial slope. Because sometimes patients come with a very high tibial slope. When there's a high tibial slope, inherently the femur is pushed backwards, and you may want to do a corrective osteotomy in a patient with a very high tibial slope, which keep on failing. The ACL keep on failing. So this is an important thing. And some patients who have a very low notch, in a very low notch, you probably can't do a very robust bone tendon bone graft. You may want to use hamstring going down and all that. So you have to understand how your patient. So that's where you need to evaluate why the first graft failed. Was it too anterior, excessive graft tension inflection? Was it too vertical? You need to have an MRI scan to understand all this. And the choice of graft, autograft, synthetic graft, allograft. I only use allograft when I have to do more than one ligament in that patient. In my patients, if patient primary graft is autograft hamstring, I will do a revision ACL bone tendon bone. If a primary graft is bone tendon bone, I will use hamstring or a quad tendon. So generally, basically, I prefer an autograft because I know failure of allografts are higher. But this is your individual choice. It's not wrong to use allograft, but you must understand what graft you're using to solve your problem. And also, you need to find out what you're going to do with the retained hardware. Do you remove the screws, the staples? Where is the staples? How you need to remove them? And the buttons, where is the tunnels? Is the tunnels convergent? What is the post-op management? And you need to understand the grafts you're going to use for your revision. So tunnel placement. Generally, as Miller has pointed out, 107 out of the 122 revision ACL were non-anatomic. They recommend 8 mm offset guide. Femoral tunnel should be, this is a Blumenscheid line. It should be in the 4th quadrant of the Blumenscheid for your tunnel placement of the femur. Tibial tunnel should be about 43% of the AP diameter. So this is roughly, II is your friend. Use II, image intensifier, judiciously in a revision ACL surgery, because sometimes you can be fooled. You think that you're in the right place. So use your II if need, and that will be your friend. And look at the medical records. What happened the last time? What graft was used? What fixation was used? Was the post-op cost too aggressive? And look at the slope, look at the alignment, look at the posterior tibial slope, and look at the general long leg flames and alignment, because all this will tell you, in this patient, if you do a revision ACL or primary ACL without correcting this alignment, look at that alignment. This is from the hip to right down to the ankle. The alignment falls, the medial mechanical axis falls here. If you do ACL reconstruction in this patient, you are doomed to fail. You're not going to have a success. So you need to correct the alignment first, and then you may want to do the ACL in the same setting or the second setting, according to your expertise and your availability in your center. So this is the X-ray of this patient. If you do an ACL in this patient, he's definitely going to fail because there's going to be a lot of lateral thrust opening on the lateral side, and the collaterals will cause elongation of your ACL. Look at the CT scans. Look how big is your tunnels. Where is the implants? And then that will give you an idea whether you want to use a bone tendon bone with a bigger plug, or is there any other double screws you're going to use, how you're going to manage your fixation. Look at the MRI, look at the other structures, look at the meniscus, look at the cartilage. Where is the tunnel widened? Is the bone plug incorporated? Where is the bioscrew location? Do we need to remove it? Will it come into your place? So these are the things you need to evaluate to understand whether how you're going to manage your revision ACL. Look at the tunnels. Whether you're going to use the same, if tunnel is in a good position, you want to use the same tunnel. If they're non-anatomic, you may want to use a different tunnel. And look at the tunnel. Are they going to converge? Where is the aperture? Where does it end? So where does it end? And where is the trajectory? Is the trajectory going to be in a different place? If the trajectory is different, you may come in another area and come to the same aperture. So you need to understand whether you need to ream a new tunnel, use the previous tunnel, or create a blended tunnel. This is things you need to look at the one-stage option. If the tunnels are too big, there's too much of ballooning of your tunnels, you may want to concern bone grafting first and coming as a two-stage reconstructions. So complication of revision, these are common complications, but I will talk to you what are my preferred technique. I will do one stage wherever possible. Single bundle anatomic reconstruction is my answer. Retention of hardware when possible. I will not go around hunting around removing all hardware. I will leave whatever is not my way. I will leave it alone. Autograft is my preference rather than allograft. close post-operative physiotherapy. I will tell my patients to go slow, let biology take place. I will not push them because generally the results of revision is lower and the tunnels are bigger. You push them too fast, the tunnels dilate and you end up having a poorer result. Have all the other things, tunnel dilators, hardware, remolded, extra fixations, bone graft, all that fluoro II in your system, in your OT available when you're doing this case. So I'll just go through some of the challenging cases and then I will end up with lateral bone bruises. First case, 30 years old. I had unable to stand long, right knee pain 10 years ago, giving way. He had a PTB reconstruction 11 years ago, and he had all the signs of failed ACL reconstruction. And he's also had some discharge noted on the wound tibial aspect. This was ACL reconstruction done many, many years ago. And you can see there's no more ACL. His alignment was okay. And in this case, he had a bit of meniscal damage as well. And we went on, and you always examine the patient under anesthesia. It's very important to examine your patient under anesthesia. You want to examine, to look at the drawer. You want to rotate the leg, rotate and examine the posterolateral corner. You want to make sure that you're not missing any other concomitant pathology. Yeah. Then you want to go into a scope and you can see 10 years ago, the tunnel was placed a bit higher because we knew now that you want to go anatomic, you want to go low down just behind the residence reach. I was able to place a new tunnel in a new trajectory and new aperture without any problem. And I use a hamstring graft, and where previously was a bone, tendon bone, I use a hamstring graft, and none of the implants were coinciding with the previous implant, and he did well. This second patient, 32-year-old, had a knee pain when cycling and brisk walking. He had 2 ACL reconstructions done in Canada. He's a Canadian. 1998 volleyball injury, torn, twisted. He had an ACL reconstruction done hamstring. In 2003, he re-injured his knee, twisted, and then hamstring reconstruction done from the other knee. Just imagine the other knee. So this is basically a surgeon preference as well. If you're familiar with hamstring, you will keep on doing hamstring and taking hamstring from the other knee and did ACL. But again, he came to see me with medial joint line pain. His attachment was positive and examined him. His PLC, posterolateral corner was lax, lateral corner was lax. And I look, you turn the patient prone and see, do the dial test. You can see this foot is rotating more. But his alignment is okay. From hip to ankle is center. So alignment was fine. And look at that, he got a previous ACL reconstruction. He's starting to get early OA. The graft is attenuated and there's some chondral injury. And you can see the graft was placed too vertically. And basically, again, examination under anesthesia. You all right? All right, let's say you internal rotate your leg. Okay. When you internal rotate your leg, you should not get anterior drawer. If you still get, if your internal rotation, it should be stable. If internal rotation is still moving, your posterolateral corner is gone. Again, under arthroscopy, you see a very vertical graft. I was able to do a bone tendon bone autograft in a new tunnel with new aperture and trajectory. And I also reconstructed the PLC in the same setting. So basically in a revision ACL, you need to identify what caused the failure. If you know what caused the failure, you're able to address all of it systematically, you have a good result. And managing patient expectation is very important. You have to tell them patient revision reconstruction does not yield same results as primary ACL reconstruction. And especially in this guy, this is a third revision for him. Okay, this is a result. You can see I use a double fixation on the tibia, all right, a bio screw and also a backup with a screw and a wire. And that's the whole bio screw on the femur. That's the whole button. And now let me take you to the other case. 39 years old, fall from staircase, twisted left knee ACL reconstruction, hamstring, November 2009, 4 years before revision. Anterior drawer positive, Leishman positive, and this is how he looks. His right knee, he had a bone tendon bone. He was quite happy. This was done in the States. He was studying there at the time and he came back. And then this is the hamstring ACL done 4 years ago. The other thing which I think is good is when a patient had PTB on the other side, try to give him back the same thing. Because patients always tend to compare and they always say, oh, I probably had the right thing. I would have got better with it. Because right knee is not complaining. So in left knee, he had a hamstring reconstruction 4 years ago and that reconstruction failed. And his alignment was good. Hip to ankle, the alignment was good. There was no alignment issues. Always do a long leg flims. And you can see on the MRI, the graft is torn, meniscus is torn. Okay. And then, okay, let me go back. Let me go back here. Sorry. Look at this button. This button is in the tunnel. This button is in the bone. So basically the reason why he failed This button is in the bone. The button got incarcerated. It did not flip. If you look, the button is here. All right, the button is in the bone, in the femur. So the button got incarcerated, so there was graft laxity, because sometimes you need to flip the button out. If the button doesn't come out, it get incarcerated. With time, the button migrates and get laxity and failure. And probably there was a contribution of new trauma, and maybe there's an external component of rotation, which is extra-articular component of pivot shift. So in this patient, I did a meniscectomy, I revised him, autograph revision of ACL, of bone tendon bone. Previous ACL was hamstring. There was a femoral tunnel blowout with button incarceration. So I had to do post on both the femur and tibia. Be prepared to do all this. I did a augmentation with McAndrews procedure to reconstruct the ALL or Sigan's ligament. So this is the arthroscopy. You can see some cartilage damage. You can see this is the femur. In the left knee, you can see there's a tunnel blowout. I can't put any screw fixation here. So I did a post fixation for the femur, and that's a bone tendon bone going in. And I did a McAndrews or ALL reconstruction, which I passed it through below the LCL to control the lateral, control the pivot shift, and then I fix it with a fit biointerference screw. So this is how the X-rays look. Here a post there, here's a post here, and then I also did a ALL reconstruction, which is basically to control the pivot shift. All right. So which patient which I will do a ALL? And looking at the recommendation by Ingisakos, patients who have a grade 3 pivot shift, patient with revision ACL reconstruction with no obvious reason of failure, is always good to add in a lateral control of rotation. Patient who are doing contact sports, patient with generalized ligamentous laxity, patient who have high risk of failure. In my practice, if I'm taking patient for a revision surgery, I will always add in ALL reconstruction. This is my practice for the past 5 years. Okay, because I know, as I mentioned by Engelbrechtsen and Samuelson, iliotibial tendinitis decreased load on ACL graft by 43%. So when you do the lateral side procedure, it will reduce the force in ACL. So generally, you're getting higher chance for the ACL revision reconstruction to succeed. I will take you to this patient. It's a 21-year-old patient of mine who had a futsal injury about 4 years ago or 2.5 years ago. Reconstruction done by me. I'll just show through X-rays and MRI and arthroscopy pictures. So this was his X-rays. Look carefully. This is 4 years ago. Look carefully the X-rays. You can see on the MRI, there was a lateral indentation on the femur. On the X-ray as well, that time was not so prominent, but on the lateral view, you can see indentation. I went ahead. I was not very cognizant with the fact of this 4 years ago. This is about almost 8 or 9 years ago patient. All right. So you look at ACL was torn. I had a small radial tear. I did a meniscectomy, and I did a hamstring ACL reconstruction. But 2.5 years, this is post-op X-rays. I felt was very happy. I did a good job. I said, good job done, Charanjit. And 2.5 years post-reconstruction, he comes back with knee instability, locking. Symptoms started 4 months before he sees me. Very active in sports and gym. He cannot recall. He tells me he doesn't know whether he had any fall or injury or anything like that. Look back at his X-rays. All right. Now you can see the lateral side, there's bigger indentation. On the MRI, you can see a big indentation. It's a lateral bone bruise type 3. So basically, I did not address the lateral bone bruise at that time, which resulted in failure of the ACL. So basically, the ACL is torn and the lateral deep chondral damage with bone bruise on the lateral side. So why it failed? This is part of the lecture, which is given the courtesy of John Bartlett, my guru, my sifu of the knee. All right. The French is talking about ALL or lateral tibial bend tenodesis. And they have, since 1960, Lemay has been talking about it. They presented 2,000 cases in 1979 in the first International Society of Knee meeting. And basically what this is like the shoulder. Shoulder, you get a heel sex deformity when it goes to the glenoid. It's the same thing in the knee. The femur comes in the front and locks to the lateral tibial plateau, and that causes indentation due to instability, rotatory instability. And this is like a heel sex in the knee. And when this, we know the subchondral bone provides load distribution, stability, and congruency, and articular cartilage support. So when you get this indentation, type 1 is just fraying. Type 2, there's a small indentation. Type 3 is a deep indentation. So when you have this in type 1, you can leave it alone. You don't have to do anything. You just do the ACL reconstruction. But in type 2, you got a deep bone. You have to do something on the lateral side because you don't want this bone to go into the tibia. So you want to reduce the rotation of the knee. So you want to do a ALL reconstruction to reduce rotation. This is type 3, it's deep. So in type 3, you probably need a bone graft to get this up. Otherwise, your ACL reconstruction is bound to fail. So my suggestion would be in grade 1 ACL reconstruction, grade 2 ACL and lateral augment, grade 3 ACL, lateral augment, and bone graft. So this is what I will do. I'll do lateral extratendidosis, and you put it deep to the bone and get it sorted out in type 3. Also do a elevation and bone graft for the lateral femoral condyle. So in summary, in conclusion, technical error is the most common reason for primary ACL reconstruction failure, ladies and gentlemen, and due to femoral tunnel malposition, look for it. Understand cause of failure for each case. Key to successful revision is understanding the cause of the failure. Don't forget lateral bone bruises and lateral augmentation, and not to be overcritical of reconstruction done elsewhere, because things change with time, understanding change. And with that, I thank you.